righty, everybody. Thanks for participating in that poll. While we wait for Dr. Ramirez, here's his presentation. Let me introduce you to Dr. Ramirez. Uh, he is a true neuroendocrine tumor specialist, primarily of the lung. Um he's a thought leader in the field of NETs, and he's presented at many of our conferences as well as many other conferences. Multiple peer reviewed publications, active in clinical trial design. What else can I say? Please welcome Dr. Ramirez.
Hi, Bob. Thanks for that introduction, and I want to thank you and Marianne for the invitation. NCAN has always been a great organization to work with, and it's we're working more towards learning more and more about this disease, and we certainly appreciate your help with this. So today I'm going to talk about how I work up and treat neuroendocrine tumors of the lung. So I see all different types of neuroendocrine tumors, including those of the lung. And I'm also a thoracic oncologist and see general thoracic oncology, so your non-small cells, small cells, and mesotheliomas. So what we'll start out with is by saying lung cancer is certainly a very common cancer, but the good news is the rates are dropping. Now, this is a slide that primarily looks at those patients with the non-small cell lung cancers. But so what we're going to talk about here is that 2% of patients with the carcinoid tumors of the lung. And what we'll note is the incidence of this is increasing. So this is a slide from a SEER analysis published a few years back. And what you can see is that the incidence of neuroendocrine tumors across the brain increasing, but those with the neuroendocrine tumors of the lung seem to be fastest. So one of the things that I want to convey is, symptoms and some of the misconceptions that we often see. So number one, yes, this is a lung cancer. There are many times where I come in and patients come in and they were told that this was a benign tumor and nothing needed to be done about it, never needed to be followed. So that's entirely false. This is a cancer. And the symptoms are really variable. Sometimes it's pure respiratory symptoms, so cough. Sometimes some people can cough up blood, shortness of breath. I see repeated lung infection, sometimes some chest pain, and many times I see these things picked up incidentally. So someone comes in for a knee replacement, for instance, and gets a preoperative chest X-ray and finds a nodule or a tumor there. So the symptoms really vary. What's unique about this type of cancer is it is like with the rest of the carcinoid tumors, these can produce hormones causing symptoms. So carcinoid syndrome we see from time to time. It's pretty uncommon, but I mean, all of these things are pretty uncommon, but we see them from time to time. Cushing's syndrome, if we have an excess of ACTH, acromegaly, or even SIADH. So some of the steps in the workup, it starts with your doctor, and you really need a good history and a physical exam, and that's going to be followed up with a chest X-ray. So this is a patient of mine who came in with coughing up blood, and he undergoes this chest X-ray, and you see this mass on the right side, and then this is followed up with a CT, and you can see this. Unfortunately, I don't have a pointer where we can actually look at this, but on the right side of the chest, you can see this mass. So when we see that, what do we think about? Well, there's a lot of different things that could be. The most common thing to me that looked like what we see in non-small cell lung cancer, but it could be a small cell. In his case, it turned out to be a carcinoid tumor, a big carcinoid tumor. It can be other types of metastatic cancers, lymphomas, plasmacytomas, schwannomas, but it doesn't have to be cancer. There's other causes of lung nodules and lung masses as well. So it really needs a dedicated workup. So some of the diagnostic procedures that we do, some include bronchoscopies, where the pulmonologist will place a tube into the airway, and they're able to look for any obstructive lesions. A mediastinoscopy is an actual surgical procedure, minimally invasive, that can allow visualization of the mediastinal contents. So that's the area in the middle of the chest. Endobronchial ultrasound is a special type of bronchoscopy where they can actually do biopsies through the airway and allow evaluation of lymph nodes. A thoracentesis or a pericardiocentesis are for those patients who have fluid either in the pleural space or in the pericardial space surrounding the heart. If we can't get to it through these ways, sometimes we do a CT guided biopsy or even an open surgical biopsy. This is just a cartoon of the anatomy of the lungs, and you can see on the left the different colors, and these are all lymph nodes. This is a diagram of on the top right is a diagram of endoscopy that's done, and then on the bottom right is a endobronchial ultrasound probe. So there's different types of lung nets, and they range from very indolent cancers to very aggressive. And really how we determine this is what they look like under the microscope. So what we see is typical carcinoids, atypical carcinoids, large cell neuroendocrine carcinoma, and small cell carcinomas. And what we really want to focus on here is to really define these types of cancers. So one is something called the mitotic index, so how many mitoses we're seeing, and also the presence or absence of necrosis. So when you're looking at your pathology report, these are the things that we really want to focus on. Now, I know we heard about Ki-67. Now, that's not really indicated right now, and it's not part of the classification. But I think there probably is a role for Ki-67. There's been lots of groups, including ours, that looked at this, and it turns out the higher the Ki-67, the more aggressive this is, just as you would expect. So maybe in the future we'll see Ki-67 as part of the classification for lung neuroendocrine tumors. So then after we get our diagnosis, we want to look at functional imaging. So we have the older technology called the Octria scan, and you can see a picture of that there. And then we have the newer technology. So we have the gallium-68 dotatate PET-CT and also the copper-64 dotatate PET-CT that Dr. Wolin had discussed earlier. So these are what I would advocate for are the PET-CTs, either the gallium or the copper. These are going to deliver the best imaging with lower radiation exposure than the Octria scans. It's more convenient, and you can see the night and day differences on the pictures there. So if your center does not offer a gallium PET or a copper PET, well, then I think it may be best to try to seek out an institution that does offer this. Lung nets really do require a multidisciplinary approach, and we do have a weekly neuroendocrine tumor board. We also have a weekly thoracic tumor board where we discuss all of these patients with the various specialties and come up with a treatment plan. So I often get asked, what is my stage? This is just a simplified diagram of this. It's much more complex. So in the top, you can see a stage 1. These are generally the smaller tumors that have not spread to the lymph nodes. Once they start spreading to the lymph nodes, your stage goes up. So if they spread to that first order of lymph nodes, or get to a certain size, you become a stage 2. If they spread to the lymph nodes in the middle of the chest, the mediastinal lymph nodes, that becomes a stage 3. And if they spread distantly to other organs, that's a stage 4. So treatment for early stage pulmonary carcinomas is surgical resection. So I advocate for patients seeing a dedicated thoracic surgeon who is skilled in the management of resection of lung cancer. So someone who does a lot of this. So traditionally, lobectomy is a standard of care. And the lymph nodes definitely need to be evaluated because survival depends on lymph node status and stage. And when it comes to adjuvant therapy or chemotherapy after treatment, this remains controversial, but I'm going to point out, I'm going to have a slide addressing this. So these are the types of surgical procedures that we do with the lungs. So this is they range anywhere from a wedge resection, where essentially they take a small piece of the lung with that tumor, to a segmentectomy, which is part of a lobe, to a formal lobectomy. Again, pneumonectomy is where they remove the entire lung, and then there's something called a sleeve pneumonectomy, where this is sometimes they can remove a segment of the bronchus. So this is a study that looked at those patients who had positive mediastinal lymph nodes or hilar lymph nodes, and how they did with or without adjuvant chemotherapy. And what this is a large number of patients. They're typical carcinoids and over 100 atypical carcinoids. So it turns out that those patients who had adjuvant chemotherapy with your typical carcinoids actually did worse than those patients who did not have chemotherapy. And then when it came to the atypical carcinoids, it looked like those patients did not derive any benefit from the use of chemotherapy. So right now, we don't have really good evidence to support the use of adjuvant chemotherapy in those patients with node-positive disease. So these neuroendocrine tumors can metastasize, and you can see this is a study of over 5,000 patients with about a third of them being lungs, and it shows that the incidence of metastasis was about 27%. Things do need to be followed. So what are our options for advanced pulmonary neuroendocrine tumors? So sometimes we can observe them. So it really depends on what's going on at the time. If the disease is stable, if we've got documented stability over a course of many years. But when it does come time to treatment, everolimus is the only FDA indicated medication that we have. Somatostatin analog have a role. Chemotherapy has a role. And the radionuclide therapy with lutetium-177, if you're positive on your imaging, and progressed on an SSA. So some of the other options: stereotactic body radiotherapy, something called endobronchial therapy with photodynamic therapy. There's liver-directed therapy, and please don't forget about clinical trials. So Dr. Wolin had spoken about this. This was the use of everolimus in patients with neuroendocrine tumors of the lung or GI tract, and randomized to placebo. And what was discussed earlier is this does have a role, 50% reduction in the relative risk of progression. So it's something that we use, and again, this is really the only FDA indicated treatment. So somatostatin analogs, I believe, have a role in patients with neuroendocrine tumors of the lung. These are two studies, the PROMID study and the CLARINET study, using octreotide LAR and and lanreotide, respectively, and you can see a benefit in progression-free survival. However, I would caution that these are done in midgut neuroendocrine tumors and also gastroenteropancreatic neuroendocrine tumors. There were no lungs in these studies, but there are no completed prospective studies in patients using SSAs in neuroendocrine tumors of the lung, but retrospective studies show that activity with both lanreotide and octreotide. So we talked about PRRT. This is the mechanism of action. I won't belabor this too much, but essentially lutetium binds to that somatostatin receptor. It internalizes it into the cell and emits beta radiation. And that induces cellular damage and the formation of free radicals and causes cell death. So this is the NETTER-1 study, which randomized patients with those progressive neuroendocrine tumors of the midgut to either lutetium or octreotide LAR at a high dose. And what they found was a very big increase in progression-free survival. And also there's also other studies that look at quality of life, and this has really changed the way we treat patients. So, but again, this was done in midgut neuroendocrine tumors. So, what is the evidence for patients with neuroendocrine tumors of the lung? So we have several different studies that looked at patients with neuroendocrine tumors of the lung, primarily retrospective. But again, these show that this is certainly a beneficial technique. So you can see the PFS in a few of these studies is approaching 30 months. So PRRT is guideline approved for lung neuroendocrine tumors. So even though the FDA label does not say lung neuroendocrine, it is guideline approved. So this is there's 3 different guidelines, including the COMNET/NANETS guidelines that were just published earlier this month that support the use of PRRT. So this is one of my patients. He's 62. He had an atypical carcinoid tumor of the lung. He received, this is after his resection, he had recurred, and you can see on the left pre-PRRT with widespread disease. He got 2 cycles of treatment, and this is what his subsequent scan looks like. And he's about 9 months from his last PRRT and still looks great. So there's something called SBRT, or stereotactic body radiotherapy, which uses short courses of dose-intensive radiation. We've been using this a long time for patients with non-small cell lung cancers who are not surgical candidates or decline surgery. But we've found that it can be useful in patients with those neuroendocrine tumors of the lung, the carcinoid tumors, who do not want surgery or decline surgery or aren't surgical candidates for whatever reason. This is a retrospective analysis of SBRT in patients with typical carcinoid tumor. It looked at patients who had either had SBRT or conventional fractionated radiation, and it turns out those patients who had SBRT seem to do better than those with conventional radiation. This is a study that from our center that looked at a total of 8 doses in 7 patients. And what we can see here on the right is the disease status. Some had everybody benefited, so with either complete response, stable disease, or partial responses, and it had 100% local control rate. So this is certainly an option. This is one of these patients included in this series. So this is, you can see the the tumor in her left lung. We gave her 5 fractions, so 5 days worth of radiation, which are only a few minutes each session, and you can see later on that year, the following year, subsequent imaging shows a dramatic response. There's liver-directed therapy. So this is a patient. You can see the large lung tumor on the left, but look at her liver on that bottom window, pretty packed with disease. So she was started on everolimus and also received liver-directed therapy in the form of transarterial chemoembolization. And what we can see here, the following year, that lung tumor is actually smaller, and she's had a dramatic response within the liver, not only because of the liver-directed therapy, but there are studies that show synergy with liver-directed therapy and everolimus. So finally, I don't want us to forget about clinical trials. Obviously, medicine does not advance without research, and often, we sometimes forget about this and focus on, what's approved right now, but there's many things coming down the pipeline, and we've got to look for these. So where do you start? Ask your doctor. Many times, we have lots of different clinical trials that are available. Some of the patient support groups, NCAN, Carcinoid Cancer Foundation, Net Research Foundation have a list of things that are out there for patients and where to go. And then there's a website that we use called clinicaltrials.gov. It's sometimes a little cumbersome, but it might be worth just checking out and seeing what's out there and asking your doctor about it. So this is just a screenshot of what that looks like. So you type in your condition and you just hit search, and out comes a list of different trials. And I think right at the top is one of the trials at our center. So it's a very good tool that we use all the time. So to wrap it up, this is sort of my algorithm. I get my functional imaging to start out with, and then I go to our tumor board and we have a multidisciplinary review, and essentially that discussion focuses on, can we take this out or can we not take it out? If we can take it out, they go to the thoracic surgeon, and then surveillance. Again, very, very, very important. If we cannot take it out, we talked about it, a number of different options. So the somatostatin analogs, everolimus, liver-directed therapy, PRRT. There's a few others there. So it's really meant, we do have lots of different options for this disease, and we're learning more and more about this. So I'll stop there. And as always, I'm always happy to answer questions. And if there's my email there, so please feel free to reach out. Thank you.
Yes, well, thank you, Dr. Ramirez. I think that's a good culmination to some great presentations this morning.